So welcome all of you to our 24th live webinar on orthopedic principles. This time we have Professor Vijayendra Singh from Kent, United Kingdom. Professor Vijay Singh is one of the leading upper limb surgeons in Kent and southeast of England. He works as a consultant orthopedic surgeon at the Medway Maritime Hospital NHS Foundation Trust. He qualified from Vadodara in India in 1992 and undergone higher surgical training in the UK. He undertook 3 fellowships in Australia and the United States. He continues to be actively involved in upper limb research and has published over 40 papers in national and international journals and a few book chapters. He's a keen teacher and committed to teaching, and as reflected by his appointment as a visiting professor and co-program director for minimally invasive surgery at the Canterbury Christchurch University. He's also been awarded the clinical tutor titles at the Brighton and Sussex Medical School as well as the Royal College. He teaches regularly on the Regional Orthopaedic Registrar Training Program as well as supervisor of MSc conducted by Brighton University. So today he's going to talk about the hand section for the fellowship examination. And it's our honor and privilege to have Professor Vijayendra Singh for our live webinar. Over to you, Professor. You can share your screen.
Thank you, Hitesh, and it's a great privilege and honor to be able to help you with this fantastic effort that you put in. Now, the idea of this is to give a flavor of what to be expected when you're sitting the FRCS or the exams. Now, the exams are quite structured these days, as you may be aware, so there's no conflict of interest. The aims of the exam is essentially on one and only one, is to assess if the candidate is ready to take up a job as a consultant. It doesn't test the knowledge or surgical skills. I think the key thing to remember is what it tests is the safe management of patient. And this is based on the fact and to try and understand how much the candidate has actually learned over the last, 3 years or 6 years or 8 years, whatever time they might have spent during the training. Now, this is the broad sheet that each examiner gets when marking the papers. 6 is where is the pass mark, is what you should aim to get. 5 is where you are on the borderline, and if you've done good in some other parts, then you might be pulled through. But yeah, aim for at least 6, and always in your good subjects, try and get a 7 or an 8 so you can compensate in some other parts. Now, there are 4 oral tables. I'm not going to go into much details of that, but the last 15 minutes, and these days, as I said, it's all structured. So there's 3 questions for 5 minutes each. Occasionally, if you run out of the questioning, then you may go into the 4th one. I think this is the most important thing. Listen to what the examiner is asking and just do not go on a rant of what you know. And this is very true, especially in trauma scenario, as I will show it to you. Usually there's a first question, which is the settling question to get you comfortable, and then you get it going. And then there is enough time for you for the candidate to show their understanding and knowledge of the management skills. So these are the broad questions that for any situation that you may be asked to think about. One is, why am I being shown this? Followed by usual opening question. Listen carefully, as I said. Pause for a few seconds before you reply so that you can formulate an answer. And suggest to continue till you are stopped. Now, this is kind of what my personal view on each of these is. The examiner will stop you as and when they require for you to answer whatever they want. So just for example, this patient. So This is a clinical picture that you will be shown. And what are the things that you need to consider? So basically, this is what you need to see. What is this? What relevant history to take? What else to examine? What is the likely cause of this? How will you investigate? And how will you manage this? Now, what I'm going to do is to look at each of these separately. Okay, so what is this? Now, if we go back, so what can you see is essentially a picture of hands. You can probably say this is of a slightly older patient. The key thing here is that this patient has got muscle wasting of the thenar eminence. Hope you all can see that. Hitesh, is there a way I can get a pointer or something?
That may be, you have an option at the bottom of the screen, but it may be difficult right now for you.
Okay, that's fine. So essentially, hopefully you can all see there is muscle wasting, thenar muscle wasting on both the hands. So what is this? It's essentially, the way I would say this is a picture of both the hands showing significant wasting of both the thenar eminence of the hand in a slightly older age group patient. So in my mind, I'm thinking this is most likely to be a carpal tunnel. So what relevant history to take? So history I want to know is whether this patient has got any pins and needles in his hands and numbness. The key thing about the pins and needles and the numbness is that the surgery, if one is thinking about a carpal tunnel release, then the surgery will help with those symptoms. Once the patient develops numbness in the median nerve distribution, then it is less likely to improve and the outcome is unpredictable. So this is the chance to show that you're thinking on a more forward basis and how you're going to formulate the management plan. Next is what else to examine. So what else you want to know is to look for any more widespread wasting of the muscles of the hand. So typically you would look for the hypothenar eminence, and the best way is to ask the patients to hold their hands like that. And then look at the back of the hands, especially looking for any wasting for the first web space and guttering of the other introsia. The first dorsal introsia is the biggest and is the one that is easy to see if there is an ulnar nerve problem. Now, the most likely cause for this is severe carpal tunnel syndrome. And to diagnose that, you've done your history, and in history, you need to ask for any neck pain or radicular pain, to rule out a double crush syndrome, or whether this is just because of the cervical spine problem. Now, confirming the diagnosis investigation, apart from that, you would want to rule out any other things. EMG studies is what is advisable, but again, that is a bit not controversial, is not done by everybody. So my view would be to say whatever is being done in your practice or where you have worked. So if your consultant who you're working with does EMG studies, then I would say that yes, I would get EMG studies done. The rationale for doing that is that it will give you a baseline study, as this is one where the results are likely to be unpredictable or less predictable. And so if you have a baseline study and if the patient has persistent symptoms, which I often see, then you've got something to compare this. How are you going to manage this? So essentially the management depends on the symptoms, as I said. The surgery is mainly for relief of pins and needles in the fingers. If the patient has got no pins and needles, then one has to be very cautious about advising surgery. The muscle wasting is less likely to improve. And also, if there is numbness already in the hands, then it is less likely to get better. If it does, it's unpredictable. The discussion could then go on to, if it's in a younger age group patient, what else could you do for the muscle wasting? So the gametes transfer is one that is commonly, when I say commonly, is the one that is recommended in younger age group patients, but again, the numbers of that being done isn't that significant. So Hitesh, is this okay?
That's fine.
Okay, and are we getting questions to ask?
You can go ahead and we can get to the end.
Okay. So we've done all of these things. Now, again, this is another clinical picture, and one's got to think about, again, if you go on the same line, so what is this? Okay, so this is a clinical picture of both the hands. The first picture is showing, the top picture shows a test, and on the bottom picture, you can see the hands of a patient with significant wasting of the dorsal interossei. And on the top picture, I can see there's another test being performed to assess the adductor pollicis muscle. And in this patient, because they've got ulnar nerve palsy or paresis, they are recruiting the flexor pollicis longus on the left hand, and that's why the thumb is flexed, as their adductor pollicis is not working. My provisional diagnosis is an ulnar nerve compression. The common site of ulnar nerve compression is the elbow, but it can happen in the wrist or can be a hard nerve lesion. And I would like to take more history and examine the patient. So that's my setting out answer to begin with. The next then will be, okay, what history you want to take. So the history I would like to know is if the patient has got any pins and needles in the hand, especially the ulnar 2 digits, whether the patient has got any history of neck pain and radicular pain. Is there a history of surgery in the neck? Is there any pain in the elbow? Now, this is quite vital in ulnar nerves, patients presenting with ulnar nerve symptoms, as often there are patients who have got osteoarthritis in the elbow, and there may be an osteophyte which is pressing onto the ulnar nerve. And often patients are unaware of that they have an elbow problem till you actually ask the patient. So elbow pain and elbow stiffness is quite important in this scenario. Examination-wise, obviously you can see the muscle wasting. You would also look for the hypothenar eminence, whether there is any muscle wasting, and look on the palm as well to see if there is any muscle wasting. And then after that, you would do your testing. I mean, you can clearly see that the ulnar nerve is involved with the Froment sign, and that's how you do it. And you also can test the interossei. And the key thing to remember is that when you're doing it, is that you should not hold the paper like this. You should be holding the paper like you're asking the patient to hold. And of course, the sensation in the hands, and also have a look what's called as an ulnar claw digit. What the ulnar claw it shows is that the little finger and the ring finger may have a bit of a contracture like that. And that's also described as an ulnar paradox, because although the deformity is more for the patient with an ulnar claw hand, the lesion is lower and less involves less of the problems. And the reason for that is that if you have a higher lesion, and if it's severe, i.e. around the elbow or in the neck, all the muscles in the hand are affected, including the long flexors, and hence patients are unlikely to have a deformity. If the lesion is lower, especially the Guillain Canal compression, because the long flexors are spared, they keep contracted, and so that's why the patients have claw deformity, and that's called the ulnar paradox. So we've done that. What else to examine? What is the likely cause? So the commonest cause for the ulnar nerve compression still is idiopathic. Often it can be because of osteoarthritis around the elbow. It can be because of trauma and causing subluxation of the nerve. Around the wrist, often it is because of the injury. How do you investigate this? Certainly in an ulnar nerve compression, you need to get EMG studies because it's not as classic as the carpal tunnel syndrome. And this is also likely to tell you the level of compression, whether it is in the neck or higher up. Sorry, in the elbow or higher up in the neck. How will you manage this? So again, management principles. I would suggest that you need to base this on the patient rather than having a standard answer that there's operative and non-operative. This is not what they're interested in. This is not an MRCS exam or an MBBS exam where they're looking for option. They want you as a day one consultant, what you're going to do. So for example, in this patient, once I've examined and established that there is an ulnar nerve compression, in my opinion, there is no role for a non-operative treatment unless the patient is surgically not safe to undergo the surgery. So I would say that once I've investigated, I would explain the condition to the patient and would advise an ulnar nerve release plus minus anterior transposition. The transposition would be based on whether, in my practice, is based on if the patient has got a subluxing nerve after the release, or if the patient has got a fixed flexion deformity, most likely because of trauma or osteoarthritis. And in those situations, then I would do an ulnar nerve transposition. And then they may take you onto the bits more about how to do the transposition and what to expect and things like that. And that depends on how your YY is going. The other thing they could ask at this stage is look at EMG studies and how you read them. But by that time, usually you can say that it's fine. So next slide. Again, looking at this, I would say this is a clinical picture of hands on two patients. And I can see that there is a well-formed cord. And the upper picture, I can see it's on the right hand. And in the bottom picture, both the hands are involved. On the right hand, there is a well-formed cord causing contracture, mainly of the MCP joint, although I cannot be sure about the PIP joint. On the bottom picture again, I can see there is a well-formed cord causing significant contracture of the ring finger with PIP joint appears to be about 70 to 80 degrees. And there also appears to be some contracture of the MCP joint. The little finger is also held in flexed position, although I cannot see any cord in the little finger. My provisional diagnosis here is a Dupuytren's contracture. This stage could go in a different way. So what history? So again, remember, this will come either as a table YY or you may get it as a short case. And the answer is that I would like to take history, and I would take relevant history. So what are the relevant history? One is functional problems, and as you can clearly see, certainly with the bottom picture, that this patient is likely to have significant functional problems. So simple things like washing your face, getting your hand in your pocket, driving, and in the picture on the bottom, he would have difficulty with everything. Other history is any history of epilepsy, alcohol abuse, any liver problems, and importantly, whether there is a family history of the same condition. And often they may not know about exactly, I mean, certainly it may be less important in India, but certainly in the UK, or if you're coming across in any Western countries, then this is seen on a fairly regular basis, and you're most likely to get it on either a hand table viva or indeed a short case. Now here, so the diagnosis here is pretty straightforward and easy. The next will be, how do you examine the hand to assess the deformity, and when do you advise for intervention? So the key thing is that you should be able to isolate each of the joints to assess the deformity. So to assess the MCP joint deformity, what you do is you flex your PIP and the DIP joint, and then you push this finger, the MCP joint, into as much hyperextension as you can. If not, if it's got a cord and if it's tight, then it may stay fixed like this. And that's the level of MCP deformity that is there. And you can measure it with a goniometer. And the accepted level of MCP deformity is 30 degrees of contracture. Now, for the PIP joint, what you need to do is to flex the DIP joint and hyperflex the MCP joint, and then try and see how much you can extend the PIP joint. So the key thing is that you must get the MCP joint contracture out of the way, and then try and extend the PIP joint or the DIP joint as it may be involved. And that is the degree of involvement in that digit. The important thing to remember here is that any degree of PIP and DIP joint involvement is considered as relevant for advising intervention. In the MCP joint, there is more tolerance. And the reason being is, if you remember from the anatomy class, the collateral ligaments of the MCP joint are stretched in flexed position. So even if the MCP joint is flexed 70, 80 degrees, once you release the Dupuytren's tissue, there is a very good chance that this will go into full extension. Whilst in the PIP and the DIP joints, the collateral ligaments are stretched or longer in extension. So what happens is, when there is any flexion deformity, is that those collateral ligaments shorten. So even if you release and remove the diseased tissue, there is likely to be a residual contracture in the PIP joint. The other thing that you need to examine once you've done that is to look for any previous surgeries. And if the patient has had surgery, then you need to be able to perform a digital Allen test. And essentially, I'm sure you all know of it. And essentially what you do is run your fingers down, squeezing the digit on the side, and then you release one of them to see if there is any collateral circulation. This is important in revision surgery, especially in revision cases, as if the patient has had previous surgery, their vascularity may be compromised, and there is a higher risk of neurovascular injury in revision surgery. Now, next will be, how will you investigate? The Dupuytren's diagnosis is mainly clinical. The other thing to also examine once you're there is the back of the hands. And I think there is a slide, maybe not. No. Is to examine the back of the hands, especially the knuckles, to see for any Dupuytren's tissue there, which is called as Garrett's pads. Also ask about any lumps in the feet and offer to examine the feet. In men, where it's more common, about 10 times more common, ask about history of any penile involvement, although I wouldn't suggest that you ask to examine the patient. It doesn't change your treatment for the hand. What it does tell you is the aggressiveness of the condition. Now, about the condition itself, I mean, you could probably spend the whole 15 minutes of the Viva talking about Dupuytren's, but they will stop you at 5 minutes and move you on. So what are the options that you could be asked, depending on where you are on the, where it's asked? If it is asked on short case, then you're likely to go down the clinical examination route. Whilst on the table, you're most likely to be asked for surgery. Now, the surgery, the indications are deformity, which is causing functional problems, and the generally accepted levels are 30 degrees at the MCP and any involvement of the PIP and the DIP joint. Having said that, if a patient is a manual worker and has got significant lumps in the palm, then you may offer that to excise that lump. Now here, again, the treatment will be asked is what is the treatment for this and how do you manage this? So again, for the patient in this one, you would say that, you would offer them surgery, and the surgery would be based on dependent on patient characteristics, but the most common intervention that is done is a limited fasciectomy and correction of deformity. Now, until January, February of this year, the Clostridium histolyticum, or Xiapex, as it was known in the UK, or Xiaflex in the US, was available, but from February time, this has been withdrawn from the European market, so that is not available, but it's something to remember. That is a collagenase injection where you inject it in the cord, and 24 to 48 hours later, the finger is manipulated to correct the deformity. And there are a number of studies that you must be aware of, and the outcomes have been shown to be equivalent in terms of recurrence following a simple fasciectomy compared to the Xiapex injection. The advantage of the Xiapex injection is that it has got less of morbidity after the procedure in vast majority of the cases, but I'm not going to go into the details of all of that. Something for you guys to read up. The other thing that you're likely to be asked is to be able to draw Z-plasties, and this is quite commonly asked. So again, it should come fairly quickly rather than having to think on the table. So whilst you're listening to this, you can sit and practice doing some Z-plasties. The types of incisions can be asked that you would do for the Dupuytren's. You could be asked the various cords and the bands in the hands. And again, you could be asked to draw about that. And if you're doing very well, then you may be asked about some post-op rehabilitation. So we've gone through what is this relevant history, what else to examine, what is the likely cause. I mean, this is a genetic condition. It's an autosomal dominant condition seen mainly in men. It's more commonly seen in the Caucasian of Northern European population. Until 2-3 years ago, I used to say I haven't seen any Asian or Afro-Caribbean, but now that record has gone. I have seen one Afro-Caribbean and one Indian guy with Dupuytren's, but they were born and brought up here. Investigation, this is a clinical diagnosis. If there is any other underlying condition that you are suspicious about, then you may wish to investigate this. And we briefly talked about the management of this condition. Here you have 4 different options. You have a needle fasciotomy, which is reasonably popular in Europe, especially France. And with the needle fasciotomy, the MCP joint contractures in here in the palm are more amenable to needle fasciotomy rather than in the finger, as in the PIP joint contracture. And the reason for that is in the palm, the neurovascular bundle stays where it is, whilst if the PIP joint is involved, the lateral digital sheet forms a lateral cord, and a spinal cord. And what that does, it may bring the digital nerve into the center of the finger, and it's very unpredictable. And while doing the needle fasciotomy, you could sever the digital nerve, and hence I only restrict myself to doing needle fasciotomy in the palm of the hand. So that is generally restricted to patients who cannot undergo surgery or who do not want a longer period of rehabilitation. The standard procedure, or the commonest procedure, is a fasciectomy, wherein you make an incision in the palm and remove whatever tissues you can. You cannot ever do a complete fasciectomy because you do not know where else the tissue is. In severe cases and in recurrent cases, you do a dermofasciectomy. Essentially, what you do is you remove part of the skin, and then a skin graft is put either from the wrist here or often from the inner arm. When you're going to do this, you must warn patients, especially if they've got hairy arms, that the hair is likely to come back in that palm. The other two options that are done uncommonly is fusion procedures for recurrent deformity, and often and sometimes an amputation of the finger. That is usually reserved for a recurrent disease or in the elderly, where there's severe deformity and you want to do one procedure with less rehabilitation and less chances of things not working. So this next slide is another clinical picture. So this is a picture of a finger of a patient showing a cyst on the left-hand side at the DIP joint. And on the picture on the right-hand side, it shows significant nail bed deformity. Probably there has been some infection in that finger. And my working diagnosis here is a mucus cyst, most likely to be arising from the DIP joint, often likely to be associated with an underlying osteoarthritis of the DIP joint. So if we look at the questions that I had put up first, so what is this? We've described that. What relevant history to take? So the history important here is whether this is the first episode. Often these patients will present with multiple episodes of infection or recurrent infection. Often this cyst bursts. They may have pain in that digit or in other digits in the hand, suggestive of more widespread osteoarthritis. And also important to ask if they've had any procedures in that same digit or in any of the other digits. That will help you with formulating a plan. What else to examine? So essentially what you're examining is examining the hand to look for any specific features of osteoarthritis, knobbly fingers. If there are any other joints which have got a similar cyst that is present. And after that, you need to check for any movement in the DIP joint, and this will help to assess or sort of make a plan as to what you're going to do for the patient. So the next question is, what is the likely cause of this? The most likely cause is underlying osteoarthritis. It can happen without an underlying osteoarthritis, but I say probably more than 95% patients do have an element of osteoarthritis. How will you investigate? So what you need is to have plain radiographs of the hand, which will show you the amount of osteoarthritis that is there, specifically to look at any osteophyte that may be pressing, especially on the nail bed on the finger. At this stage, you may be asked to draw the nail bed and the nail matrix and be able to identify the structures that are there. And again, I would suggest that you need to learn those. How will you manage this? So the management depends on the symptoms of this patient. Clearly, the one with the picture on the left-hand side, you could elect to wait and watch, and you give the advice to the patient. Aspiration of the cyst or needle puncturing on its own is not advisable, as the cyst is likely to recur quickly. With the patient on the right-hand side picture, clearly the cyst or the osteophyte is pressing on the nail bed, causing this, so waiting is not likely to help. Now, the treatment is usually one of two. If the patient has got reasonable movement in the DIP joint, then you may elect to just do a excision of the cyst with removal of the osteophyte. If they have got little movement or are in severe pain, then the only option would be to do a fusion of the DIP joint along with the excision of the cyst. At this stage, you may be asked about the incision that you need to use, that one would use for assessing or accessing the joint. And it's usually either a Y-shaped incision, or as I call it, an inverted Mercedes-Benz, sounds more posh, or an I or an H-shaped incision around the digit. Next, we're going to look at another picture. So again, this is a clinical picture of a patient's left hand. And I can see on the top left picture that the patient's hand is rested on a table. And as soon as the patient lifts the hand up, they are unable to lift the thumb up. And my working diagnosis here is most likely this patient has got rupture of the extensor pollicis longus tendon. I would like to take further history and examine the patient to confirm my diagnosis. So if we look at the first picture, the slide that is this, what is this? So clinically, this looks like a rupture of the EPL tendon. So what relevant history to take? Now, we know that most of the time this is followed by, this is preceded with a history of a distal radius fracture. So need to know if the patient had a history of fall and a fracture that was treated. Again, most commonly, this is seen in patients who have had minimally displaced fracture of the distal radius, treated non-operatively, and often and commonly around 6 to 8 weeks, maybe 10 weeks is when you would see, as the patient is starting to mobilize, that the thumb drops. It's very important to ask what functional problem they have. And the key is not to rush into doing surgery in this, because sometimes, especially in low demand patients, you may not need to do a surgery. What else to examine? Obviously, you need to examine the wrist and see what movements they've got, whether they have got any other problems related to the fracture, whether there is any scars. Sometimes it can happen because say post-surgery as well, but most commonly it is because of conservatively treated injury. What is the likely cause? We've established, again, you may be asked the theory behind this. So if it's not a post-surgical, then the reason is that the sharp edges of the fracture cause an attritional rupture. And also there is some suggestion that the vascularity of the EPL tendon is compromised as it passes from the around the listus tubercle. How will you investigate? I mean, this is a clinical diagnosis, and maybe a few years ago, you would not have done anything. And again, it depends on who sees the patient. I personally wouldn't get any further investigation as long as I have got a plain radiograph done previously to show the fracture is healing. But you could be advised to get an ultrasound if you needed to confirm that. And I see a lot of my juniors do it. So the answer is I would be happy to do a clinical diagnosis, but you need to be aware. And it's not just for this question. Often in an exam situation, you need to be a bit flexible and be aware when to change the tag. So if you say that I will, this is a clinical diagnosis, I won't do any further investigation. If the examiner wants you to investigate, then he will say, are you sure that you're not missing out on anything? Then it's nothing wrong to change your tack in that situation and say that, yeah, you will get an ultrasound scan done, but you need to justify why you're going to get an ultrasound scan done is to see whether there is any associated synovitis. You may want to say that I want to check if there is any other tendons involved, or if then to check for the amount of retraction that is there. How are we going to manage this? As I said earlier, there is no rush into operating on this. You would do put the patient in a splint, send for hand therapy to see if the symptoms can be managed. Now, it's important to remember that the tendon is not going to heal on its own, but the patient's symptom may not be bad enough to warrant any intervention, and so you could treat this in a splint and hand therapy. The reason for putting this is to ask you about tendon transfer. So once, if you go down the route of non-operative, you'll probably be told that, oh, the patient comes back in a few weeks and there is no improvement. So in that situation, you're going to do a tendon transfer for this patient, and the common tendon transfer done is EIP to EPL transfer. So the extensor indicis proprius is transferred to the EPL tendon, and they will ask you the procedure, how it's done and how you identify the tendon. So if you look at the back of the hand, in some people, you may be able to see the two tendons on the index finger quite easily. So in here, I can feel it. So the index proprius tendon is the more ulnar tendon on the back of the hand. So the one which is on the ulnar side. Now they'll ask you probably to draw an incision. So you need one incision here, which is what I would start off with, to identify the tear and do any debridement of sharp edges, and also to identify the EPL, the EIP tendon as it comes out here. Second incision is somewhere at that level where you're going to do your repair. And the third incision is at the MCP joint. I start off with this. Once I've identified the torn tendon and the EIP, I make another incision here, a small transverse incision, and then release the EIP and then pull it out through here, and a further small incision here to pull this EIP tendon here. Next is the type of repair that one would do. So the common answer is to do a pulver-taft weave. Please read up the technique, and essentially it's a side-to-side transfer. It's a very robust repair. That's the advantage. The disadvantage is that it's a bulky repair, and in slim patient, even in a fat patient, the repair will always be noticeable, but that's what they've got to accept in lieu of getting a better function. Probably be asked of post-op rehab, so back slap for 2 weeks, and then I generally tend to get them mobilized in a splint. So next slide is, so I can see there's a X-ray, PA view and a lateral view of a wrist. And the most obvious abnormality I can see is there is a cyst in the capitate. There is also a scaphoid non-union with sclerotic margins. There is secondary changes in the radiocarpal joint. And on the lateral view, I can see the unit has extended, and there is collapse of the mid-carpal joint. I can also see there is some mid-carpal osteoarthritis. degenerative changes. So my working diagnosis is this is a scaphoid non-union advanced collapse, stage 4. If you're confident, you can say the stage 4. And then you will be asked, you may be asked about the stages of the SNAC wrist, the scaphoid non-union wrist, and you should be aware of that and some of the biomechanics. Essentially, again, if you go back to my what the questions I had put up with is, what is this? So this is a scaphoid non-unions advanced collapse. So the relevant history to take is whether there is a history of trauma, whether there is any history of any previous surgery to the wrist, and in the history also the handedness of the patient and the job the patient does. And this is relevant because you will need to tailor the treatment according to the patient needs. So if there's a low demand patient, then you may not need to do anything to this. Now, what else to examine? You need to examine if the patient and take history if the patient has got any median nerve symptoms. Occasionally they may have. Look for any other injury or any other problem in the upper limb that may affect your post-operative rehabilitation. What is the likely cause? Obviously, a previous injury of the scaphoid fracture which has not healed. How will you investigate? I personally would not need to investigate this any further, except for if you had any symptoms of a nerve compression, then you may wish to order EMG studies. But in my opinion, there is no role of CT scan or MRI scan here. It's gone well beyond where one will be able to salvage this wrist. How will you manage this is what you will be asked. So the management plan for these kind of patients. So again, here is the importance of listening to the first question. So you may be told at the beginning that this is an X-ray of a 50-year-old man who has had symptoms in his right wrist for about a year, and he has had non-operative treatment already. So when you've been told this, then please do not start with that, I'll do a splint, I'll do a steroid injection, I'll do analgesic. The examiner has already told you that the patient has gone through the non-operative treatment and what is your next step going to be. So in that stage, you need to be asking and thinking about those questions which we have got. The other thing to check is how much movement they've got. If there is reasonable movement in the wrist, then you may be able to offer a less intrusive procedure. So what are the options here? Conservative, obviously we've discussed, and when you talk about conservative treatment, please do not stop at saying conservative treatment in whatever waiver you're giving. When you say I'm going to do conservative treatment, say what conservative treatment you're going to do, rather than waiting to for the examiner to ask. So if this was the first presentation, then I would say I would initially start off with a non-operative treatment in the form of splints, activity modification, referral to hand therapy, and I would also consider a steroid injection. And that's when you stop and then wait for the examiner for the next question. If that is already done, then your next step will depend on the patient's and the patient's expectation and what you can offer. So my advice would be, depending on the movements, I could either offer a wrist arthroscopy with debridement, removal of excess body, and a partial wrist denervation, and then you would go down the route of denervation. But the definitive answer, if it's a symptomatic manual worker, would be to undertake a wrist fusion. Then the discussion is likely to go on to a partial wrist fusion and a complete wrist fusion. And here again, I would suggest that you stick to what you have seen or what you are read and aware of it. Personally, I would do a complete wrist fusion here. And the reason for that is that the patient already has got mid-carpal osteoarthritis. So a partial fusion is less likely to work. If you do just a mid-carpal fusion, but this patient has already got a radiocarpal osteoarthritis and a radiolunar arthritis. So anything short of a total wrist fusion is less likely to work here. And at that stage, you would probably be asked about the approach to the wrist and the compartments of the extensor tendons, which you need to read up. Is that how we're doing?
Yeah, that's great. I'll
We
just
do a
read up,
second part later, I think.
yeah, I'll just read up some of the questions that have come in.
Yeah.
Someone is concerned about the withdrawal of Zalfex, that is the enzyme collagenase.
Yeah.
And he says that it was a revolutionary treatment and its withdrawal is going to severely affect the treatment of debilitants.
It has, but it's a commercial decision, really. It's across Europe. And although there is no official line why this has been done, my personal view is that it's 10 years since Xiapex was launched. And they're probably coming to the end of the patent. And once that does, the cost drops. So the cost of Xiapex in the UK, the cost of that, and I don't know if anyone of has used it, you only inject about 0.4 mils is the maximum that is injected. And the cost of the injection is nearly £1,200. So that's my cynical view, but we can't do anything about it.
You're right. You know why? When this question was put up in the chat box, I just looked into the data on why Zalfex was withdrawn, and the company says it's due to economical reasons. So you're right.
Yeah. So but it will come. Whether it comes end of the year or next year, I'm sure there'll be other companies who will be interested in manufacturing it. So it will come.
Once the patent is gone, once the patent period is gone, I think a lot of other companies can produce it, right?
Correct.
So it should be back soon.
Yeah, it will be. Yeah.
Okay. So the other question is not exactly related to the FRC's Viva, but someone has asked me, do you think a percutaneous needle fasciotomy can be used as a precursor surgery prior to your definitive fasciectomy? Because it can reduce the severity of the disease and then your second surgery becomes a bit less aggressive.
It doesn't work like that, unfortunately. The needle fasciotomy, as I said, I only do it for patients who are not surgically fit. I mean, these days, even in those patients, you can do it under a regional anesthesia quite safely. So I think needle fasciotomy, if the patient has got really low demand, that's the only time I would do. Or the other category, which I did one recently, is a reasonably fit guy, but he didn't want to go through the 3 months of rehabilitation that one would go through if you were doing an open a fasciectomy. But no, I don't think that it's right that you do a little bit and then you do a bit more later on, because the recurrence rate is more than 50%.
And another question is, what is the role of the open palm technique of Makash that was described very much earlier?
Yeah, so it is still used. The open palm technique is one where, as the name says, that if the deformity is severe and if you cannot close that wound, then you leave it open and it granulates and heals secondarily quite well. And sometimes, although as surgeons you're tempted to close it, what happens is you start to stretch it, that skin dies and it secondarily becomes an open palm technique. So do not hesitate. And if you see somebody who's got severe deformity, always warn the patient. So it's important, if you warn the patients preoperatively, they are prepared for it. It's when when the patient isn't prepared, it's when they have issues about it.
Okay, thank you. There's yet another question. What are the indications for a tendon transfer in ulnar claw hand? So when do you really think about a tendon transfer?
Tendon transfer. I'll be honest with you, I have no experience with that, so I'm not going to answer that. I don't know. It probably needs to be asked by a plastic hand surgeon. I've not seen one done, if that helps.
Okay. I think here it is very common in India because, you know, leprosy, it's much less now, but at one point, Professor Paul Brand, he established the leprosy center in India and he was doing all sorts of tendon transfers for leprosy. I think that was the reason why.
Remember, the problem in leprosy is different than the ulnar nerve compression that I would see. The problem in leprosy is that the nerve itself is involved.
True.
Even though you may release the nerve, the function is less likely to improve. Whereas if you've got an osteoarthritic elbow or an idiopathic compression, once you release the nerve, the patient is likely to improve.
Okay, so one can be said. Yeah, maybe it's an intrinsic pathology in leprosy, and what you see is an extrinsic pathology due to external compression.
Absolutely.
Once you the compression, you're relieved of symptoms.
Spot on.
Okay. Yeah, see, they may come up with questions again and they'll write it to me and I can pass it to you later on. I think most of the guys just got up from their sleep in the UK.
Okay, yeah, no problems.
So thank you, Vijay, once again for sparing your time with us and your generosity for providing your time with us to teach residents and young surgeons is really great. And thank you once again for joining us. And
thank you. Maybe I've got a few more to it next time on shoulders.
Yeah, great, Prof. We'll have an action on shoulders later.
Yeah, we can do shoulders later. Yeah.
Okay. Thank you once again, Dr. Vijay.
Thank you.